This week on the BackTable podcast.
If you have an ASC or even an OBL and you're not tracking any type of a quality metric to develop one that's important and CV focused, maybe it could be as simple as patient complications or patient transfer. Currently, there hasn't been data requirements in this space, right? So in many cases, folks aren't even tracking any data to measure and manage their performance. And I highly recommend it. If you're not participating in any type of registry that you're tracking one or two metrics, don't just say you're providing quality care, actually be able to demonstrate you're providing quality care.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Hello, everyone. Welcome to the BackTable podcast. Today we have another special episode. We're going to be covering another outpatient or ASC topic, namely the importance of safety and quality care in the cardiovascular ASC. Today, I have with me Kristen Richards. Welcome, Kristen, to the show.
Well, thanks for having me. Great to be here.
Yeah. And so, Kristen, I'd like to start these out for our audience to do a quick intro. Tell us, a little bit about yourself, where you're at. I know you're currently in transition, so tell us a little bit about that.
Sure. Yes, I have been working for Atlas Healthcare Partners for the last couple of years, and last Friday was my last day, and I'm transitioning to a new role, similar role in the cardiovascular ambulatory space, and I will be joining Cardiovascular Logistics the end of the month. So excited about that new opportunity coming my way.
Congrats on that. So tell us a little bit about your role at Atlas and at Cardiovascular Logistics. What is it that you do at these companies?
So my role has been and will continue to be leading the cardiovascular ambulatory surgery space. And with Cardiovascular Logistics, I will also be leading some of the office-based labs as well out there in the community at large.
And were you not doing as much around the OBL space when you were at Atlas?
Correct. Atlas is just an ASC company. They're a management company, so they just manage ASCs. We did have some acquisitions through the years that we started out as OBL and then transitioned them into a fully operational ASC.
Yeah, I mean, the audience knows this, but I've really only had experience in the OBL space over the years. A couple of the OBLs that I worked at, or actually at least one of them, considered converting to an ASC. That is a big undertaking, as many of in our audience know, as you probably know. We've kind of covered that topic in the past with like Terry Yates. But today I wanted to talk a little bit more for something that we haven't really addressed in detail is, patient safety in the outpatient space. Because I think there's a lot of skeptics out there who maybe are hospital employees or in academics who think, that's great that you guys can do all these procedures in the outpatient space, but what about patient safety? We hear about things, there's a New York Times article, we hear about bad things happening. And, I know that this is part of your job is making sure that these new operations are safe for patients. And so I wanted to, ask you, but first, how did you develop this interest and passion for quality care in the outpatient space?
Yeah, so it's a great question. And I have been in the cardiovascular space, I'm going to age myself here a little bit, but over 20, 25 years. And I started in the hospital space, leading cardiovascular, the division within Banner Health, worked for Banner Health for many, many, many years and worked in that space and then transitioned to industry. I actually worked for Philips for almost 10 years. And during that time, I spent a lot of time traveling across the country, working with hospitals across the country on their cardiovascular, how to improve their clinical, financial, operational performance in their CV space. And the last year or so, I started moving towards the CV ASC space because we started to see some movement into that area. And that's when I really started to think that, this is something that I want to continue to entertain and look towards. And a lot of it had to do with the fact when I walked into some of these CV ASCs during my time with Philips, I was somewhat taken back about the things that were lacking in that space that alarmed me. And I knew that, all right, we have to do better. We have to do better in this space to get to what you just said about the skepticism. CV ASCs, I would say, are the new kid on the block, right? There's a lot of unknown out there. So if you don't do it right out the gate, you could be having problems with patient care, quality care, that type of thing.
Yeah. And so do you look at, maybe where there's been success in other specialties like GI or orthopedics and try and bring some of that to the cardiovascular space?
Yes and no. And let me
Yeah. I'm just curious because it seems like historically, like those specialties have been in that space longer, right? Am I wrong?
No, you're right. Right. They kind of set the standard, so to speak. And ortho is a great
Yeah.
example of that, right? So now we're starting to see total joints being done in the ASC space, right? So there has been this transition to more complex procedures, I guess you would say, in the ASC space. So I think they did set the standard, but I'd also firmly believe that CV is different, right? It's different. It's different. And I would say that in the cardiovascular ambulatory space, although these are low risk patients, they're the highest risk patients coming to an ASC space.
Yeah. I mean, they're vasculopaths, right?
Absolutely.
There's a reason why you need cardiology clearance in the hospital for a lot of, surgeries is because of vasculopathy, right?
Right. That's exactly right, which makes it really important that in the cardiovascular ASC that you are selecting the right patient for the right procedure at the right facility, right? And if you don't have standards in place to do so, you could be letting any type of patient come in your doors, and that could eventually or ultimately be a safety risk in your center, right?
Yeah, absolutely. First, I wanted to talk a little bit more about the benefits of out of hospital care, whether it be OB or ASC. People talk oftentimes about improved patient experiences, staff satisfaction, and then, efficiency in care. Care to touch on those before we move on to like the other things like infection rates and stuff like that?
Absolutely. You hit on those are some key things that I have seen firsthand really come to fruition. And it has to do with, if you think about the location, and just start there at a location. Patient going into a hospital and navigating a complex facility, right? And they walk into a building, they're looking up at the signs, they're trying to figure out where they need to go. There's a check-in process. There's this whole process by which is somewhat nerve-wracking for patients coming in the doors and maybe even their families, where if you think about an ASC, they're driving up to the location. This is what I love hearing from patients about. It's like, boy, I pulled in, I parked in the front, I walked into the building, I was greeted right when I walked in. I sat for maybe 2 to 3 minutes to fill something out, and they brought me right back in to see your nurse and set me up and getting me ready. So there is something to be said about just that efficient, just a stress-free kind of environment, low-cost environment. They're coming in, they're being seen immediately. In most cases, they're out of the facility within 2.5 to 4 hours. So that's amazing. Whereas they might spend a whole day or 6 to 8 hours at a hospital unnecessarily, whereas they could come into one of these facilities, be in and out, and going home to spend time with their family, be in their own bed, in their own home, and that type. There's just, it's very rewarding. And to see the patient experience scores and the physician experience scores, those are things that we have tracked through my career here, and they are amazing. They're outstanding.
Yeah, you're right. I mean, just starting with the free parking and,
Yes.
not having to, get lost in the hallways, multiple registration spots, all those things it just adds to, a big long day, even for something minor, something like as small as a thyroid biopsy, in the hospital. It is kind of goofy when you think about it. So also one thing that people bring up is you mentioned physician satisfaction, but also just staff satisfaction. I mean, there's generally no call. It's usually Monday through Friday kind of situation. Care to speak about, what you've seen in terms of staff satisfaction?
That's huge and very beneficial and an easy retention and attraction type environment, right? Where folks know that they can come in and there's no weekend, there's no call, there's no holidays. You should have a scheduled shift, whereas, all my time in the hospital setting or in my travels through my career, it's been, I'd walk into a lab and you're just talking to people like, I don't even know when I'm going home tonight, right? Whereas in the ASC space, you should be pretty regulated on your schedule so your team knows when they're coming in and when they're going to be able to go home and be with their families. And you're able to do that in a really positive way that is impacting, the staff, the physicians, and the patients. It's a win-win-win.
Yeah. Yeah. And so I do want to talk a little bit about, because you mentioned total joints, right? So what's the top thing when I think of a total joint, the thing that comes to mind first and foremost is infection rates, right? And in cardiovascular procedures, we don't think about that as much, right? There's not these big open procedures, tend to be minimally invasive, small nicks. Infection tends not to be as big of an issue unless you're placing maybe defibrillators, Mediports, stuff like that in the cardiovascular space. But can you talk a little bit about what you've seen in terms of infection rates in the hospital compared to the cardiovascular ASC space?
Well, the one big thing I would say is that you have to track it, right? You have to track it. And in the hospitals, they do a really good job at tracking infections. It's part of what they have to report. And maybe not in the ASCs is that done as regularly as it should be, right? I highly recommend it, right? So if you're looking at, you mentioned device implants, those are something that we should and you should be actually tracking to make sure that there is no infection, the patient isn't returning to the physicians. And that's not that difficult to do, and having follow-up with your physicians on those patients that came in your building within 30 to 60 days and following up with the physician's office to understand, how's that patient doing? Did they come back? Is everything going okay? So that you're tracking infections. You should have a mechanism in place to do that. A lot of places don't. I'll just be perfectly honest around.
Yeah, I think that you're right. I mean, it's just like one more thing to have to worry about, think about, but maybe it doesn't affect the bottom line immediately, because most people, I think, in the ASC space, at least starting out, are worried about all these other things. But you're right. You have to track these things, especially when you're trying to demonstrate the benefits of getting out of the hospital. And so I think that's solid advice, is tracking important things like that. So we mentioned some of the drivers of doing some of these procedures that are appropriate in the cardiovascular ASC that are more around patient, friendliness, obviously patient safety. I do want to talk a little bit about like the economic drivers as well, but let's dive a little bit deeper into safety. I mean, what are the things do you think of that are top of mind? Like, is there a checklist in your mind in terms of, okay, guys, you think about opening an ASC or you've opened one, these are the top 3 things that are like essential for making sure that every patient that walks into your center is going to be safely taken care of?
Well, I would start with the fact that there's not a lot of data that exists today around this, right? But we do have SKY recommendations that, I will say this though, they're SKY recommendations, but they're for the PCIs in the ASC setting. But they're really good guidelines that at a minimum you should put into place to, again, make sure it's the right patient for the right procedure at the right facility. And if you follow that, you can feel pretty confident that you're going to deliver high quality care and provide a safe environment for your patients. That at a minimum, they exist today. It's out there. Those should be followed and part of your practice by which patients are coming into your building for a PCI or even a diagnostic cath. Okay.
You mentioned when we were talking offline about things to address, even just, how patients are coming in the door. What are some safety things that we think of, just like people being in the center, not even getting on the procedure table, anything like that people need to think about when they're designing their center even?
Again, it's understanding the types of patients. These are the low-risk patients coming into your building, but we just said a few minutes ago, right, that these potentially are still the highest risk patients coming into an ASC setting. But you do need to understand, although you have a very similar setup as a hospital, you don't have everything that a hospital has, right? So the size of the patient matters. What are their comorbidities? Those matter. Those are important. If they have breathing challenges, you might not want to have them come into your facility, right? If they're very heavy, how are you going to get them up to the table? Do they require a total lift? A lot of times, again, you don't have a Hoyer lift. I'm trying to remember what those are called in the hospital setting, but you don't have a lift to be able to put the patient on the table. So you want to make sure, again, that you're providing a safe environment for your patients, but also for your staff, right? Because you don't have everything that you would in a hospital setting because you don't need to. Again, it's around the right patient selection. So if you have a process by which patients come in your doors through pre-admission testing. Somebody's calling them. They're understanding what kind of patients coming in their door. They're looking at comorbidities, and you have a really good understanding that, again, that they're the right patient to come into your facility.
Great. And before we get into, some of the economic drivers of this outpatient space, anything else that people, that docs need to keep in mind around patient safety, maybe in the post-op space, right? Like after they've had their procedure done, you have a holding area or a post-op area. Is there anything that you think of like, oh, that's actually like there's a pitfall there that docs need to be aware of?
Not necessarily, but I think, again, if you have standards of practice by which patients come in, how they're treated, and then what their post-op care is, and you have that set up and everybody's on board and understands it, they've been trained on it, then again, your patients will come in your facility easily and they will be discharged in an easy fashion, right? And you are addressing any potentials that could happen, and everybody's well aware, well informed, and well educated on how to handle that.
Yeah, I mean, that's where I've seen bad things happen is in, not thinking fully about like sort of the post-procedure care. People think, oh, the procedure's done. There's some observation time and we get them out the door. But thinking about, okay, what if something bad happens in that post-procedure observation area? But you're right. There's standards of care that need to be followed and so forth, and making sure the staff is trained up on those things. So anyway, I want to jump into what other factors are contributing to a lot of these procedures being delivered in the outpatient space. On the economic side, is it some of the skeptics paint this picture of, oh, well, you just docs are going to make more money. That's why they're trying to do this. I don't think that that's entirely true, given all the other things that we already mentioned. But for docs who are considering this, what are some of the economic drivers of moving some of these procedures into the outpatient space?
Well, I think first and foremost, it's around providing a lower cost setting for our patients, right? And providing them with greater access, and having these ambulatory surgery centers have been very well received across the country, right? When you think about how ortho and GI, all those things we just talked about, but having the capabilities to be able to access facilities that you didn't have access before, that provides a lower cost setting, that shouldn't fundamentally, I'm hoping that's where folks are starting, right? Is that we want to embrace this value-based healthcare environment and provide a lower cost setting for our patients. And then once you've decided on that, now you're going to develop an infrastructure by which patients can safely come in and out of your centers, and that you're providing high quality care. And so hopefully those are the drivers behind that. Are there financial drivers? Yeah, sure, there absolutely is. And that could be that the physicians are investing in these centers, right? They are the owners of these centers. They could be doing it on their own. They could be doing with joint ventures with the hospital. They could be doing it with the health system, and as well as a management company. So there are drivers, some financial incentives around that. But again, hopefully, fundamentally at the core of it, you're really focused on providing a lower cost setting for your patients in the community.
Yeah. And also, I mean, just on the industry side, are we seeing the cost of capital equipment coming down to making it more sort of affordable for physician owners to be investing in these centers? Before it seemed it was probably a bit cost prohibitive. And that's why, really a lot of the larger, fixed units were only found in the hospital and so forth. Have you seen any technological advancements assist in this drive to the outpatient space?
I definitely have it. And you are right. The cardiovascular space, the equipment is incredibly expensive, right? These fixed systems. But we are seeing some, I would say, some costs coming down, as well as having some innovative business models by which you can obtain this equipment, whether it's through leasing or it's through market share of devices, device utilization. I think there are some creative business models out there that exist that you potentially weren't able to participate in the hospital setting, but you could do it in this setting. And we've actually, in my career, we've been able to capitalize on that, so to speak, and be able to put stuff in without causing a huge capital outlay to the physicians.
Yeah, exactly. I mean, I've seen a lot of industry partners getting involved to help assist with that as well, which is great. It allows for not to take such a big risk getting into this space because they're eager to But at the same time, it does seem like almost like a gamble for some, and especially in certain areas, which leads to my next question is, are you seeing ASCs pop up more? Traditionally, we think of them in, cities, but are we seeing them pop up more in rural areas to help kind of address these care deserts that exist throughout the United States?
So that's a great question. And I think we're starting to see some, but nowhere near where it probably should be. So I think that's a very fair question. And then some markets, the growth is incredible on the CVASC space. And sometimes I don't know if that's a good thing or a bad thing. I live in Arizona. There are 16 CVASCs in Arizona today. That's a lot.
Wow. Yeah, that's a lot. Yeah. So how do we, that's the other kind of skepticism we're seeing is people are like, oh, well, OBLs and ASCs are popping up all over the place. Do we have too many? Obviously, some states have a certificate of need requirement. Does Arizona have one?
Arizona does not, no. But you're right. They're starting to come down, right? The CONs are starting to come down, but there still are states out there that have them, that make it a little bit more challenging, right? You have to have the capacity. You're actually taking capacity, which is what you should be doing anyway, right? You're taking the lower risk patients out of your hospital to free up space for more complex procedures. And some states are doing, really looking at that to make sure that it's being done appropriately.
Right. Which I think is a good idea, but sometimes it's over-regulated, right? To a point where you're not delivering enough care. Yeah. Well, do you have any stories that anything that you've seen out there that where it was really like restricting actually delivery of care?
Well, there are states, right, that still aren't allowing PCIs to be done in this setting. So that in some cases is restricting this lower access, right? Or I should say creating greater access to patients are actually preventing that from happening. So there's still this high cost environment in the hospital setting that we're forcing patients to go to, right? And in some cases, folks aren't doing it because maybe they can't afford it or, right, they don't have the means by which to do that. So that's limiting, and as far as I believe, right? So,
yeah. How often are you seeing a new ASC open up, or even an OBL, now that you're transitioning this new position, open up alongside or in conjunction with or in partnership with a hospital system versus solo, or a private practice group?
Not so much the OBL environment from joining up with a health system, right? But definitely with an ASC. And that's primarily driven by health systems that are focused on their physician retention, attraction. Again, this is attraction and retention tool for health systems to partner with their physicians in a different way and allowing them to invest in a center along with keeping their partnership intact from the hospital standpoint, if that makes any sense. But it's really, really important, especially when it comes to physician alignment, because that's been a challenge across the country. If you think about that, right? How health systems and physicians haven't always been aligned, and having this type of a strategy kind of creates some stickiness around that partnership.
I think you're right. I mean, it's a great tool to retain physicians, as we've heard on the show a number of times, are feeling like a loss of autonomy, right? And maybe if you're a hospital employee and you're in the cardiovascular space and a hospital says, hey, we want to partner with you to open up an outpatient space where you can, practice with a little bit more autonomy. I think that goes a long way for physicians who are maybe feeling a little bit like they have no say in their practice. You know what I mean?
You're absolutely right.
And so that's really, I hadn't even thought about that, but I think that's a great driver for hospitals to be opening these up. But have you seen anything deterring hospitals from opening more, outpatient sites?
Well, sure, if they don't have to, right? So if there's no competition around that, if the payers aren't forcing them to do that, they want to, sadly, but they want to keep those patients in their hospital because cardiovascular is still one of the top margin producers for hospitals, right? So for them to let some of that go is challenging. So if they don't have to, they're going to keep them in their building.
I gotcha. That makes sense. They're just making more money with patients in the hospital than they would in the ASC space.
That's right.
So going back to the physicians themselves who are maybe looking to, because a lot of our audience are docs that are, they see the title of this episode and they're listening because they're considering opening one or partnering with somebody to open one. What else do they need to consider before making that leap? And how do you, in your role, help facilitate this transition?
Well, to start off with, right, again, is what's the reasoning why you want to do that? And then do you have the infrastructure to be able to successfully move forwards? And what I mean by that is going into building a center, there's a lot to it. There's a lot of financials to that, right? And so coming in and thinking that, well, there's me and my other partner, or there's three of our physicians, to be able to do that is probably not going to make economical sense, right? You really need to have the infrastructure where you have a diverse group of cardiovascular cardiologists, electrophysiologists, maybe even vascular surgeons, even interventional radiology, right? We've had this type of mix that you can successfully open up an ASC, a CV ASC, and be productive and do very well. So that matters. It matters how many folks are at the table that you want to participate with to be able to have a successful infrastructure.
Actually, Kristen, you brought up a good point, and I like to address this a lot of times when we have vascular surgeons or cardiologists on the show. Is I love seeing the practices that are multidisciplinary, endovascular. You have, like, for example, Jim Melton, Blake Parsons out of Oklahoma. They've got vascular surgeons, interventional radiologists, and cardiologists all under the same roof in the same practice, right? And you see some other variants of that with vascular surgeons and interventional radiologists, or vascular surgeons and cardiologists working together in the same practice, which is great because the skill set complement one another. If somebody's endovascular, procedure doesn't go well, you have a vascular surgery partner who can take care of the rest, right? This has evolved, right? Especially over the last 5 years, but have you seen this more of these multidisciplinary, multi-specialty practices opening up over, recently? Or can you give us a little bit, because you've been doing this for a while, like how have you seen that evolve?
So we've certainly, in my career, participated in that. And actually, I think it's been a really good partnership of having that mix of vascular surgeons. In fact, I have one center that in my past that had vascular surgeons, cardiologists, and electrophysiologists that have done very well. And I agree that diverse group of physicians can really provide some great services to their community, and a wide range of services to their community that I think is something that people should consider. It's, I will say that hasn't always been the case, even if you look at the hospital setting, right, where these folks work really well together. But I think people are more open to it as they provide an even greater depth and breadth of a complement of services in their ASC, and you should consider that. And if you have the ability and you have the relationships, it would be beneficial to not only the practice, but also to the community at large.
Absolutely. I agree with that. And I like to see and hear more of those practices developing, because I do think that the skill sets highly complement one another, and it reduces turf wars, which are really unnecessary, that often arise out of the hospital just because of oftentimes miscommunication even.
That's right.
You know what I mean?
Yep. That's very, very true.
Yeah. And so on that same vein, where do you see the out of hospital or outpatient landscape going? Like, what's your vision of the future looking forward?
It's definitely going to continue to grow. And I think what's on the horizon in the CVs, ASCs, is around EP ablations. And I think we're waiting to see if that's going to happen. It could happen as early as 2025 or maybe even 2026, where AFib ablations will be added to the covered procedure list. So I think that's the next big move that will be exciting. But I also think, and don't get scared when I say this, but I also could see structural heart procedures being done in this space, the lower complex ones being done in this space in the future, 5 years out, 10 years out or so. But I definitely see that happening for sure. And the covered procedure list is going to continue to grow, right? We see year after year. And that's what I think is really exciting.
Yeah. And you think that those procedures, the safety profile is, I guess, low enough where they can be done in the outpatient space?
Yes. I think that, right, the data is going to continue to get stronger to show that that's the direction you should be going. But that doesn't preclude you from putting safety measures in place to ensure that, again, your providing a safe environment and providing high quality for those procedures that have been added. Does that make sense? I mean,
Yeah.
I think about, we started doing in one of my centers, we're doing right heart ablations, which are commercial payer approved, but just making sure that you put a process in place, again, by which those patients come in your doors, the right patient for the right procedure at the right facility. You have to do that every time
Right.
they add procedures. You should really consider what's the pathway by which these patients come in so that we're providing the highest quality care effectively and efficiently and at the lowest possible cost.
Yeah. And any other resources for physicians who are looking to get into the space or even are already in the space and just need more information, maybe they're struggling? Any places where you can, obviously the big conferences you mentioned, Sky, are good, but those are once a year. Like anything that you can suggest that they can, reach out to?
Well, I think there's more and more information coming out from cardiovascular business, from Becker's, from the societies, right? You did mention Sky, ACC. They're actively starting to engage in this space to get a better understanding themselves, to really be a good resource for folks, to make sure that they're making the right clinical decisions and putting process in place, again, by which patients come through their doors. So I think accessing any and all those types of material is really important. There's obviously consulting services that exist today for folks if they needed to further explore or wanted to have other questions they need answered that maybe they can't find online or so forth. But those exist today as well.
Another good one that I like to mention is OEIS.
OEIS.
I don't know if you've ever been. Yeah. It's multidisciplinary. You got, again, those three specialties tend to go because it was founded by, a vascular surgeon, a cardiologist, and an interventional radiologist. And so everybody's at the table and everybody's kind of, sharing and working together. That's what I like about that one.
It's a great one. And you're absolutely right on that one, right? You have a great resource of a diverse group, right? Really sharing best practices and things that they've seen in their own centers. I think it's a great example as well.
Yeah. Well, Kristen, that's all the questions I have. Anything that I'm leaving behind that you'd like to share?
I think I would say this, and that is, if you have an ASC or even an OBL, and you're not tracking any type of a quality metric to develop one, right? One that's important and CV focused. And I'll give you an example. Maybe it could be as simple as patient complications or patient transfer, right? If patients transfer from our center to a higher level of care, why did that happen? Was there anything that we could do that would prevent that from happening in the future, right? There isn't data. Well, currently there hasn't been data requirements in this space, right? So in many cases, folks aren't even tracking any data to measure and manage their performance. And I highly recommend it. If you're not participating in any type of registry, that you're tracking one or two metrics to ensure you're providing, don't just say you're providing quality care, actually be able to demonstrate you're providing quality care.
Absolutely. It reminds me of that book, Measure What Matters, which is, it's more around, business entrepreneurship, but it's directly applicable to healthcare, right? I mean, measure what matters. If complications matter in your practice, which they should, obviously, then you need to be measuring them when they happen, how they can be avoided. Same thing, like you said, with, transfers, which is basically oftentimes happens because of a complication. And then do your M&M, right? Sit down with the staff and talk through, okay, what happened, guys? How can we prevent this going forward? And those are the key steps, like you mentioned, towards having an actual, safe place for patient care. The quality, you should be shooting for better care than the hospital, right? Not just matching it, but better, because that's what patients expect.
That's right.
Yeah.
That's exactly right.
Yeah. Kristen, thank you so much for sharing your expertise on the show. Looking forward to getting this one out.
Well, I appreciate you having me. It was great talking to you today, and hopefully people will enjoy that and they'll learn something from what we talked about today.
I think so. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritts, and co-hosts
Chris Beck, Sabine Dawn,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening.